So the reason that we have patients that are problematic, complicated, stay in the ICU for a long period of time, require lots of resources, is at some level there's multiple organ dysfunction, inadequate tissue perfusion, and so we must be dealing at the root of it with the determinants of cardiac performance. And that's kind of the genesis of why it is that we're looking to apply this in these patients.
Goal-directed therapy is critical in doing the best thing that we can for our patients, because as we know, even just a brief episode of hypotension or non-calculated mismanagement can result in a prolonged ICU course and a prolonged length of stay and significant mortality and morbidity for our patient. I was able to put the device in and get some pretty good measurements from the heart, all within less than 15 minutes or so, and determine that it was just hypovolemia. There was no component of sepsis or anything like that. Once we got sort of facile with the device, you can see the frequency with which we place Swanganz catheters really sort of took a nosedive for us, and we're to a point now where we'll at most have one patient in our 30-bed intensive care unit with a Swan at this point. They'll have a lot of the ImaCor sticking out of their mouths, but not as many Swanganz catheters anymore. You know, it's actually a whole lot quicker to use the ImaCor than it is to place a Swanganz catheter. I mean, floating the thing in and getting the images is actually very quick, and you get the clinical information just like that.
What I have found as we've moved forward with this and been transitioning from using predominantly PA catheter to using this is that your confidence in the data is the trade-off, in that you are now getting a direct look at the left heart and getting a direct look at your cardiovascular performance, cardiovascular physiology, and those independent determinants of cardiac function that has made that need to obtain those images beneficial.
In my eyes, in my thought, this is probably superior because you're actually looking at the size of the left ventricle, you're looking at the filling volume in the left ventricle, and you're not having to infer a bunch of stuff to get there. You're actually seeing it, and as you apply therapy, you can watch it expand or contract, and you can watch how the muscle, the heart muscle, responds to all that. So to me, this is a superior. It would be superior to that.
The approach to training is multidimensional. There is a good deal of help provided by the ImaCor support team. One of the nice things about this is, as I was alluded to earlier, these studies are repeatable. It's necessary to repeat them during a resuscitation, but they're also repeatable at that same time. And so that provides an opportunity for training of several people at one time, even with one patient. You can't do that with a PA catheter. You place it once and really that's it. So I find that reaching competency happens a lot quicker with this than it does with being sure that we're interpreting the PA catheter correctly.
For us, it was like you just had to put the time in, you do 10 or 15 in a row, and it just sort of clicks. And even if you walk away from it for a long time, like if I hadn't done one in a month, I could step back in and feel comfortable. I mean, it just falls back into place.
It allows you to get to their needs quicker, get the answers faster. And it provides a little more confidence because you can see how well you're doing or how poorly. You know you're not flying blind, so to speak. Maintaining tissue perfusion, preserving organs, and then saving lives.
I can look at the left heart now, and that's changed a whole lot about our approach to resuscitation, in comparison to where we were historically.
Really, very quickly here, gone through 3 different important views, if you will, with the hTEE probe. In our patient, it was helpful with our resuscitation. She was resuscitated in the operating room, but was still hypovolemic when she got to the ICU. This helped guide our resuscitation. That's not new, that's something we're used to. But in this patient, we also identified a new problem. Pericardial effusion, pericardial tamponade. That led us down another track. We'd actually weaned our pressors, thought we were headed toward extubation, had to change gears a little bit, get cardiothoracic surgery involved, and then get a pericardial window. Now we're back to that baseline again where she's off her pressors. She's doing very well, and I hope tonight or by tomorrow we'll have her off the ventilator. So with that being said, I'll stop there. I hope that's helpful. Thank you for letting us share our patient with you. I'll be happy to take questions or to kick it back to Dr. Christie or one of the other panel members. Thank you very much.